In the dim morning light of the distant past, long before the clangor of modern hospitals or the certainty of scientific diagnoses, human societies grappled with the fragile beginnings of life. The cries of newborn infants and the laughter of small children echoed through ancient tents, huts, and palaces alike. Yet what did it mean to concern oneself with the health of a child in those worlds? What knowledge existed beyond instinctive caregiving? And how did the earliest observers of life attempt to understand the unique body of a child? These were questions that human beings, mothers, fathers, healers, and wanderers, pondered in shadows long before the word pediatrics was ever imagined. The very roots of what would become the science of child care extend deep into the soil of ancient civilizations. Long before written history, in lands stretching from the fertile banks of the Nile to the sprawling plains of the Indus Valley and the courts of early empires, elders and early healers noticed something unmistakable. Children are not merely small adults. Their bodies, their cries, their rapid growth and sudden fevers spoke of something distinct, something that adult experience alone could not fully explain. In communities bound by kinship and survival, this recognition shaped the earliest forms of care. Mothers and caregivers learned through practice which herbs soothed a fever and which cooling poultices eased a tender stomach. Fathers watched anxiously as outbreaks of disease swept through camps and villages, reducing once lively children to frail shadows. In every corner of the known world, caretakers trialed remedies and shared their observations in voices passed down through sunlit courtyards and around evening fires. From the banks of the ancient Nile River came some of the earliest known written records of child health. Egyptian healers, whose practices date back many thousands of years, documented ailments of infancy and childhood on papyrus scrolls. These texts attest not only to an awareness of childhood maladies, but also to attempts, rudimentary though they were, to record treatments and outcomes. What compelled these early scribes was not merely the impulse to heal, but a profound recognition of the vulnerability and value of the young. In their careful strokes of reed pens on brittle scrolls, we glimpse an early thread in the long tapestry of human concern for children's well-being. Yet it was within the philosophical milieu of ancient Greece that some of the first systematic reflections on childhood emerged. The physician Hippocrates, known to later generations as the father of Western medicine, and his followers wrote about health and disease with an eye toward observation and natural causes. They noticed that the humors and temperaments of younger bodies varied markedly from those of adults. These early scholars recorded symptoms, noted responses to treatment, and began to speak of childhood as a distinct phase of life deserving careful attention. Far from the mysticism that colored many healing traditions, their approach sought explanations grounded in the patterns of nature itself. Across the great breadth of the ancient world, beyond the Mediterranean, knowledge about childhood also took root in other intellectual traditions. In ancient India, medical compendia such as the Susruta Samhita and the Charaka Samhita, texts that would reverberate through centuries of medical thought, contained specific guidance on the care and nurturing of infants, newborn feeding practices, and the particular susceptibilities of young bodies. These writings did not merely catalog ailments. They reflected a worldview in which the health of children was tied intimately to the well-being of the community and the flourishing of future generations. Despite these early and remarkable sparks of insight, society at large did not yet regard childhood health as the domain of a specialized art or science. In many cultures, children were cared for first and foremost by families and community elders. Healers were called upon only when illness became severe. In ancient Rome, general practitioners, families, and midwives tended to children's needs using a blend of herbal remedies, physical care, and ritual practices. They worked without the benefit of specialized training or scientific instruments, relying on experience and the wisdom of elders. The absence of formalized pediatric treatment reflected the broader view of children in these societies as beings not yet entrusted with full agency, whose well-being was the shared responsibility of family and clan. Yet even as infants and children were woven into the daily rhythms of life, bathed in basin, cradled by parent and grandparent alike, their vulnerability was a constant presence. Epidemics of infectious disease, inadequate sanitation, and the limitations of early therapeutics took a brutal toll. In some ancient societies, the tragedy of high child mortality was woven into the fabric of existence. Many families knew the heartbreak of mourning small graves beneath a tree's shade. At the same time, the losses spurred reflection. Why do some children survive while others perish? What of the young body makes it so susceptible? And how might caregivers, without the tools of modern science, help tilt the balance toward health? In the marketplaces where merchants from distant lands exchanged goods and stories, the earliest healers also exchanged knowledge. Mesopotamian clay tablets, some dating back thousands of years before the Common Era, contained prescriptions for childhood ailments. Healers noted the pulse, the color of the eyes, the temperature of the skin. They tried to understand the patterns that distinguished a teething fever from an early contagion. These efforts were imperfect and often clouded by spiritual beliefs, but they reveal an earnest quest to perceive and to ease the suffering of children. This was the soil from which later traditions of pediatric care would grow. As centuries passed and empires rose and fell, these early seeds of understanding would lie dormant in some regions and blossom more vigorously in others. What remained constant across time and place was the universal recognition that children, in their delicate stages of growth, occupied a special place in the human story. They carried the promise of the future even as they bore the fragility of the present. Families and communities endured, learned, adapted, and sometimes failed. Yet each attempt to comfort a fevered child, to soothe a crying infant, to record an observation for future caregivers, these were the first gestures toward a field of study that would eventually be called pediatrics. In that ancient world, where the sun rose on the mysteries of life, the seeds of separate care for children were sown. They sprang not from textbooks nor from formal institutions, but from the intimate encounters between caregivers and their young. As we journey forward in this story, from scrolls crafted in dusty workshops to the threshold of the first child-specific clinics, we carry with us the echoes of those earliest efforts to see children as uniquely vulnerable, uniquely human, and uniquely deserving of attentive care. The sun had long since risen over a medieval town when the first hints of a new kind of caring began to ripple through its winding streets. Yet even as market stalls creaked open and laborers hefted their tools for another day's work, the lives of children, so vivid, so vulnerable, were largely shielded from formal medical attention. In the grand sweep of history, between the flickering lamps of antiquity and the dawn of specialized medical care, there lay a long expanse of centuries where children's health was woven into the fabric of everyday life rather than treated as a distinct discipline. This was a time when care for the young existed in the margins, in familial devotion, in religious charity, in the scattered writings of learned men who pondered the humors of bodies both small and large. It was an era of care without category, a world where children were tended, but not yet seen as uniquely requiring a place of their own within the healing arts. In the shadowed halls of medieval Europe, long stone corridors stretched beneath cold arches where the sick and weary rested alike. Here, within the general hospitals and almshouses, there was no ward labeled specifically for the child. The aged and the infirm, the wounded and the frail, all shared a common space. Children found shelter in those same courtyards by necessity, not design. When illness struck a household, the midwife or family healer was summoned, a figure versed in herbs and tradition, but not trained in what we now recognize as clinical expertise. Parents, grandparents, aunts and uncles gathered around a fevered child, whispering ancient prayers while applying poultices passed down through generations. Care was intimate and heartfelt, yet unclassified. There was no medical category that separated infant from adult, and no consensus yet formed that the young body was different in essence, not merely in scale. In those centuries between the fall of Rome and the beginning of the Renaissance, children's lives were often bound up with the tumult of wider social forces. The specter of epidemic disease cast its long shadow over crowded medieval cities, and war and famine tested the resilience of families and communities. Yet unlike the meticulously recorded clinical observations that would flourish centuries later, care during this era was pragmatic rather than scientific. Children received the same salves and balms as adults. They were wrapped in the same linen cloths and laid upon the same straw-strawed beds in the infirmary. Medical texts of the age often mentioned maladies of the body generally, but child-specific ailments were rarely differentiated with much precision. The notion that a child's physiology merited independent study had not yet taken hold. Scholars and healers alike believed that childhood was a preparatory stage of life, that once a boy or girl reached a certain threshold of strength, the distinctions between youthful and adult sickness would blur. In practice, of course, the reality was different. Children sickened and died at far higher rates than their elders. It was in this context that places like Ospedale degli Innocenti in Florence began to flicker into being. Established in the 15th century in the heart of Renaissance Italy, this institution did not first open as a hospital in the strict medical sense, but rather as a refuge for abandoned children, foundlings, as they were described, left at designated doors and tended by caregivers paid by the city's funds. These places were not merely shelters. They were statements of humanistic concern in a time when social questions of belonging, birth, and survival were fiercely debated. The Innocenti offered food and shelter, education and crafts, and an attempt at continuity of life for children who might otherwise have no home. Yet medical care within such institutions was still rudimentary, driven more by the instinct to protect than by any formalized understanding of child health. Even as Renaissance thought reawakened interest in the human body, drawing upon the anatomical inquiries of earlier empires, physicians and scholars were only beginning to voice dissatisfaction with the vague, undifferentiated approach to childhood illness. A nascent wave of curiosity began to raise questions. How does a child's development differ from an adult? Why do infants suffer from conditions rarely seen in grown men and women? Could there be distinct patterns at work in a small, growing body? Some of the earliest treatises to touch on these themes began to appear toward the close of the 15th century. Bartholomäus Mettlinger, a physician practicing in Augsburg, published a book named Ein Regiment der jungen Kinder, one of the first known works devoted to the care of infants and small children. Within its pages were descriptions of early childhood diseases and guidance on nurturing the young, not as miniature adults, but as living beings with their own susceptibilities and needs. Yet such texts were exceptions, influences flickering into the wider discourse rather than signposts of an established medical specialty. Throughout these centuries, the rhythms of daily life remained the principal teacher of those who cared for children. Families leaned on tradition, on lore, on the accumulated wisdom of generations. Midwives offered advice on feeding and swaddling, learned elders recounted ancient remedies, and religious orders housed the most vulnerable in broad-shouldered institutions of charity. There was compassion in abundance, but little that modern eyes would recognize as organized pediatric care. Children's diseases were cataloged unevenly in manuscripts and oral traditions, bound up with superstition as much as with observation. A fever might be explained by an imbalance of humors or by spiritual malaise. A persistent cough could be soothed by a poultice while prayers cascaded over the bedside. The boundary between medicine and ritual was porous, and no clear category existed to demarcate the child as a distinct subject of clinical attention. These practices, for all their devotion and earnestness, reflected a deeper cultural assumption, that the child's place was within the household and community, not within the halls of specialized learning. Childhood was understood as part of the broader sweep of life. Its singular vulnerabilities were known through experience, not through precise inquiry. The wisdom of the midwife and the care of the family were paramount, yet there was no clearly defined medical doctrine to elevate those practices into a science. And yet, as questions about growth and development persisted, as caregivers uneasily noted patterns of loss and survival, the seeds of change were being sown. Across Europe and beyond, incremental shifts in thinking placed greater weight on observation and text, on written knowledge and shared inquiry. Caregivers began to distinguish between their own accumulated experience and the evolving body of scholarship around human health. Slowly, almost imperceptibly at first, a notion emerged that would later coalesce into a category all its own, that children's health might be studied, understood, and treated in ways distinct from adult medicine. This conception would take centuries to fully materialize, but in those long afternoons within general hospitals and foundling homes, the groundwork was laid. Care remained holistic and unspecialized, yet the question lingered. What would it mean if childhood itself became a subject of scientific understanding, rather than simply a stage through which all humans passed under the universal umbrella of general practice? In these pre-pediatric centuries, care without category was both necessity and norm, a tapestry of practical, emotional, and spiritual tending that kept children alive in the absence of systematic medical theory. The flaws of that era are evident in hindsight: the high toll of infant mortality, the limited comprehension of childhood diseases, and the absence of dedicated clinical frameworks. Yet in the earnest devotion of families and the earliest scattered texts, we see the first stirring of a deeper recognition that the young body, in its beauty and fragility, demanded not only love but dedicated understanding. And so, as the world edged toward the 18th century, the stage was set for the emergence of a discipline that would transform how childhood was seen, cared for, and ultimately cherished. In the crisp spring of the year 1802, in the heart of Paris, where the Seine's slow waters reflected the old stone bridges, a decree quietly changed the course of medical history. The city that had long borne witness to great art and revolution now saw a new kind of institution rise from the rubble of its past, a place dedicated not simply to the sick, but to the sick children of Paris, and ultimately, to the very notion that childhood was a category of human life worthy of its own care, its own study, and its own humanity. Thus was born El Hospital des Enfants Malades, the Hospital of the Sick Children, the first hospital in the Western world established expressly for pediatric care, opening its doors on Rue de Sèvres in June of that year. To grasp the weight of this moment, one must first understand the river of change in which it flowed. Paris at the dawn of the 19th century was a city still reshaping itself in the tumultuous aftermath of revolution. Old institutions were dismantled or repurposed. New ideas of citizenship, welfare, and public responsibility were being debated in cafes and council chambers alike. Hospitals that had once served all comers, from lepers to laborers, had grown crowded and chaotic. Childhood had for centuries been tended within the family and by charity, an orphanage here, a kitchen of alms there, but rarely had it been seen as a distinct sphere requiring a dedicated institution. That perspective began to shift as Enlightenment thought permeated medical and civic discourse, urging society to organize care not just by necessity, but by principle. The story of this first pediatric hospital begins in a building older than its mission. In the early 18th century, a place known as the Maison Reale de l'Enfant, Jesus was established as a refuge for the poor, where weary women labored spinning flax and cotton under clerical supervision. By the time the revolutionary fervor of the late 18th century reached its stones, the building had served various functions, even acting as a storage house for coal amid civic upheaval. In the summer of 1795, a decree transformed it yet again into the Maison National des Orphelins, a shelter for hundreds of Parisian orphans in need of sustenance and basic care. Here, amid corridors that once echoed with the cries of abandoned children and the shuffling feet of caretakers, the idea took shape that soon would become institutionalized. On the 29th day of April, 1802, another decree from the Conseil Général des Hôpitaux ordered the orphans away so that the building might serve exclusively those children, sick and in need of care, both girls and boys under the age of 15. Within these ancient stones, a hospital dedicated solely to childhood would rise. 300 beds were set aside, and a staff of dozens, clinicians, surgeons, nurses, prepared to tackle the vexing reality of childhood illness in ways that had never before been systematically attempted. The opening of the hospital was, in many ways, an act of both hope and humility. It acknowledged a truth long neglected, that children were uniquely susceptible to ailments that often differed in form and course from those of adults. The medical chairs who walked its halls were keenly aware that the young body was not merely a smaller version of the adult one, but a field of vulnerability and promise. They observed how fevers spiked and receded with peculiar ferocity, how undernourished limbs struggled toward growth, and how infections could decimate entire wards within weeks if unchecked by attentive care. These clinicians, constrained by the scientific knowledge of their age, yet driven by a burgeoning sense of systematic inquiry, labored to learn and to treat with compassion and rigor. The hospital's emergence did not occur in isolation. Across Europe, earlier efforts had begun to hint at the need for child-specific care. In Vienna in 1787, a children's hospital had opened its doors, and in London, outpatient clinics for children had been attempted even earlier. Yet none rivaled the Parisian institution's singular dedication to the full spectrum of childhood illness, nor its symbolic weight in anchoring pediatrics as a distinct medical endeavor. Within these walls, the rhythms of childhood, once private and hidden in family chambers, became visible, measurable, and teachable. Physicians recorded symptoms, compared cases, and sought patterns. They began to articulate in tentative language at first what differentiated one stage of childhood from another: the infant's fever that resisted common remedies, the school-age child's persistent cough that hinted at pulmonary weakness, the stubborn diarrheal afflictions that ravaged small bodies in crowded wards. Every case was a story, a lesson, and a beckoning toward deeper understanding. Yet the hospital was more than a crucible of clinical observation. It was a place of human drama whose corridors witnessed the hopes and despairs of families who brought their children through its doors. Here in the cold corridor lights, mothers watched over fevered foreheads, fathers paced the stone floors, and nurses whispered solace as they adjusted coarse blankets and administered simple remedies. Their presence infused the institution with a pulse of emotional intensity, the fervent wish that these young lives might be spared sorrow, and the sober awareness that, even within a hospital's embrace, mortality still hovered close. In the larger arc of history, the opening of El Hospital des Enfants Malades did more than treat ailing children. It heralded a new way of perceiving childhood itself. No longer was the young body merely a miniature adult subject to scaled-down interventions. Instead, childhood was beginning to assert its own rhythms, frailties, and needs, and with that assertion came a profound shift in medical culture. The hospital's name, literally, the Hospital for Sick Children, signified that shift in stark terms, carving out space in the bustling heart of Paris for scientific curiosity, clinical attention, and human compassion directed specifically at the young. Of course, the hospital was far from perfect. Its staff wrestled with limited resources, imperfect understanding of disease causation, and the ever-present terror of outbreaks that could overwhelm even its walls of stone. Yet in navigating these challenges, the clinicians of Paris planted seeds that would one day grow into a broader dedication to pediatric study and practice. They showed that children's sicknesses could be observed systematically, that patterns could be discerned, and that the lessons learned here could carry meaning far beyond the city's limits. Visitors to the site in later centuries would see parts of the original building still standing, a silent testament to an age when medical care was only beginning to disentangle itself from tradition and embrace scientific inquiry. And as subsequent generations of physicians built upon these foundations, the world began to recognize what so many caregivers had always intuited: that children, fragile yet full of potential, deserved a medicine attentive to their unique needs and respectful of their place in the human story. In that pivotal moment in early 19th century Paris, the distinction between child and adult was etched not just in hospital records, but in the collective imagination of medicine itself. The first pediatric hospital stood there, not just of stone and timber, but as a demonstration that to see and care for children with focused attention was to take a seminal step toward a more humane and enlightened medical future. The early 19th century hospital in Paris, dedicated solely to children's sicknesses, stood as a beacon in a world still awakening to the idea that childhood had unique needs. Yet it was one thing to open doors and beds for young patients, and quite another to transform that experience into a lasting discipline of medicine. Such transformation required not only places, but people, figures whose curiosity, courage, and commitment would give shape to the idea that addressing children's health ought to be a field of study unto itself. Across oceans and cultures, several such individuals emerged, visionaries whose lives and work became foundational in what we now call pediatrics. Their stories reveal a mosaic of intellectual daring and human devotion, set against the broader currents of social change and scientific awakening. In the bustling streets of 19th century New York, one of these figures took his first steps toward redefining child health care. Born in the small town of Haarlem in Westphalia, Prussia, on a spring day in early 19th century May, Abraham Jacobi would come to be remembered as the father of American pediatrics. Driven from his homeland by political upheaval in his youth, he carried not only memories of revolution, but a determination to make a difference in the lives of small children and their caregivers. After completing his medical education in Germany, he arrived in the United States and saw, with both professional eyes and compassionate heart, the glaring absence of formal care for infants and children. In the mid-1850s, he opened one of the first children's clinics in America, charging a modest fee and seeing in his young patients not merely symptoms, but stories of growth, loss, and survival. Through tireless lectures, writings, and practice, Jacobi sparked interest in pediatric problems at a time when few of his peers considered them worthy of focused study. He was among the first to introduce systematic attention to infant nutrition and hygiene, in a context where scientific understanding of disease was still in its infancy. Later in his career, Jacobi helped establish the pediatric section of the American Medical Association and served as the first president of the American Pediatric Society, lending structure and coherence to a field that was hitherto loosely defined. This was not merely professional ambition, it was a conviction rooted in the voice of lived experience. Jacobi, who lost several of his own children to illness in their earliest years, brought an intensity of personal urgency to his work. He authored influential texts addressing diseases of infancy, diet, and child welfare, sowing seeds of practice and pedagogy in a nation grappling with rapid social growth and industrial challenges. As he taught, wrote, and practiced, he built not only clinics, but communities of knowledge that would train subsequent generations of physicians to see childhood as a distinct field of human development and vulnerability. Yet Jacobi was not alone in his dedication. In Munich, another visionary worked quietly to create an institution that would bear witness to the social dimensions of child health. August Honner, born on a crisp autumn day at the close of October in the year 1811, opened a small hospital for underprivileged sick children in the mid-1840s. Beginning with only 6 beds and a busy outpatient clinic in the heart of Bavaria, His initiative grew steadily into a renowned children's hospital that combined direct clinical care with teaching and publication. Horner's work was characterized by the practical belief that children's diseases required focused study, and that physicians should share their observations and insights through journals and lectures. His contributions extended to co-editing a journal dedicated to childhood illnesses and articulating principles of physical education and care that resonated beyond the walls of his own hospital. Over decades, Horner taught young physicians to see in each child patient not merely a case to be treated, but a body in development with its own rhythms and needs. Across the Atlantic, others joined this unfolding story of pediatric vision and commitment. In the United States in the late 19th and early 20th centuries, figures like Isaac Arthur Abt, the founding president of the American Academy of Pediatrics, and John Howland, who established the first full-time pediatric department at Johns Hopkins Hospital in Baltimore, further deepened the medical community's engagement with childhood health. Abt, whose leadership helped shape professional organization and education, wrote influential texts and strove to elevate the practice of pediatrics within the wider medical world. His efforts helped create an institutional home where scientific inquiry and clinical care could grow hand in hand. Likewise, Howland's emphasis on full-time research and academic commitment at one of America's leading hospitals marked a profound shift. No longer was child care relegated to part-time practice or generalized medicine. It became a specialized domain with dedicated scholarly and clinical infrastructure. These pioneers were bound by more than professional title. They shared a conviction, emerging from the broader intellectual currents of Enlightenment, industrialization, and social change, that children's health was not merely a private concern, but a public good. They believed that disease in infancy and childhood, once hidden in the quiet rooms of family life, could be observed systematically, studied scientifically, and addressed with structured care and compassion. Their writings and lectures evoked a simple yet profound question. What does it mean to care for a life just beginning? And how might medicine serve that process rather than merely reacting to its collapse? It is important to recognize that their achievements unfolded not in isolation, but within contexts marked by profound societal transformation. As urban populations grew and industrial work drew families into crowded cities, the risks and burdens of childhood sickness became increasingly visible in public life. Cramped housing and limited sanitation made infectious diseases ever more potent threats to the young. In response, physicians outfitted with scientific instruments and clinical training began to see patterns in malnutrition, respiratory ailments, and infectious outbreaks that had once seemed chaotic and inexplicable. The very act of observation, recording, comparing, querying, became a civilizing force in the effort to change how childhood illness was understood. Pediatrics, in this sense, emerged where humanistic concern intersected with empirical inquiry. Their early efforts did not solve all the problems of child health overnight. Far from it. Mortality rates remained high through much of the 19th century, and effective therapies for many childhood diseases would not be available for decades. Yet the foundational work of these pioneers shifted the lens through which medical professionals viewed young lives. The distinction between adult and child was no longer merely intuitive. It was clinical and conceptual. Clinics, journals, professional associations, and departments of pediatrics began to appear not only in major cities but around the world, each building on the legacy of observation, teaching, and dedication, pioneered by figures like Jacobi, Horner, Abt, and Howland. In the long narrative of medicine, these visionaries stand at a crucial turning point. They moved pediatric care from the periphery to the center of medical consciousness. More than names in history, they were translators, transforming the silent struggles of children and families into language and practice that the scientific world could grapple with. As their work took root and spread, the very idea of what it meant to tend to young lives was reshaped. What had once been a matter of instinct and charity entered the realm of rigorous inquiry and public commitment. In their time, the questions they raised about growth, vulnerability, nurture, and prevention would become the cornerstones of a discipline that continues to evolve, always striving toward a deeper understanding of how best to support children at every stage of life. The echoes of footsteps along hospital corridors, first heard in the stone halls of Paris and in the modest clinics of dedicated individuals, had begun to settle into a new rhythm by the latter half of the 19th century, the measured cadence of teaching, learning, and formal inquiry. What once was a practice largely bound to the bedside, guided by intuition and occasional observation, was transforming. Physicians now pondered not only how to soothe a fever or staunch a cough, but how to explain them. They began to ask deeper questions about growth, development, organ systems, and variability across stages of childhood, and those questions pointed toward a remarkable pivot in medical culture: the emergence of pediatrics not just as care, but as science to be taught in lecture halls and laboratories. In the shifting light of the late 19th century, the outlines of this transformation begin to take shape in universities across Europe and North America. Clinics for children still bustled with young patients' cries and nurses' calls, but now young physicians gathered not only at the bedsides, but also at chalkboards and lecture chairs. They debated case histories, compared notes, and wrestled with emerging data, a shift from tacit knowledge to something approximating systematic learning. No longer was childhood illness merely treated. It was studied, questioned, and documented in a way that aspired to scientific clarity. One of the milestones of this movement was the establishment of dedicated professorships in pediatrics at major medical schools. In the United States, for example, Thomas Morgan Roch, born in the cold winter of 1849 in Philadelphia, would become the first full professor of pediatrics in the nation's history when he took up this role at Harvard Medical School in the early 1900s. Roch was a physician who saw beyond the immediacy of clinical practice. He envisioned a discipline with its own conceptual foundations, articulated in courses, discussions, and texts that would outlive any single clinician's hands. Under his guidance, students learned to scrutinize a child's pulse not merely as an isolated datum, but as part of a pattern of human development and pathology. His innovations extended into practice as well. Roch designed an incubator for premature infants, an early effort to shape the environment of care itself, and presented it to colleagues alongside his academic work. Across the Atlantic, similar developments were unfolding in European universities and medical institutes eager to enrich their curricula. Professorial chairs dedicated to the study of childhood disease were becoming more common, a testament to the steadily mounting conviction that childhood was more than a biological stage. It was an object of scientific inquiry. In Russia, for example, clinicians at the turn of the century were building programs and departments that combined medical education with specialized pediatric research, gradually integrating pediatric topics into the formal curriculum of the Military Medical Academy and other schools of healing arts. By the late 19th decade, founding societies and chairs devoted to pediatric ailments testified to the discipline's accumulation of intellectual weight. This evolution from the bedside to the classroom was not only about titles and positions, but about texts, the manuscripts, manuals, and guides that would bind experience and observation into shared knowledge. Long before the 20th century's proliferation of science texts, some of the earliest pediatric writings had already begun to chart this terrain. In the 15th century, Bartholomeus Mettlinger had authored one of the first manuals devoted to caring for infants and children. But it was only in the 19th century that pediatric texts matured into tools of formal education, rather than compendia of tradition and anecdote. In the late 1860s and 1870s, pioneering figures in the United States and Europe authored textbooks that sought to distill patterns of childhood illness into systematic chapters. organized not by whim, but by a developing understanding of disease processes, growth curves, and physiological features unique to the young human body. These early works, some passing through multiple editions, became indispensable references for students and clinicians alike, catalyzing a shift from solitary practice toward shared scholarship. The classroom, then, became an incubator of its own kind, a place where theory and practice merged, where questions about development and disease were debated and refined. Faculty and students deliberated over why some conditions disproportionately afflicted children, how nutritional states might shape physical resilience, and how observational insight could be married to emerging knowledge from anatomy and physiology. Lecture halls buzzed with energy as professors invoked cases from pediatric wards to illustrate broader principles of body function and disease progression. In these spaces, childhood ceased to be merely a stage of life observed at the bedside. It became a domain of scientific study, with its own logic and challenges. Yet classrooms did not eclipse clinics, they intertwisted. Clinical apprenticeships remained central to learning, and pupils would still follow seasoned physicians from one bed to the next, absorbing not only the technicalities of examination, but also the art of questioning. The new pedagogy integrated the lived realities of child care with the rigor of academic structure. Students learned to ask not merely, "What is this symptom?" but "Why does it manifest thus?" How does development, environment, and organism interact over time? In so doing, they stepped into a lineage that stretched back to the earliest scribes but now had the tools to probe deeper than ever before. This scientific turn also intersected with broader cultural shifts. The late 19th and early 20th centuries were an age of expanding public education and academic professionalization. Laboratories were being equipped, journals were finding audiences, and societies dedicated to specific arenas of medicine multiplied. Pediatrics, once an unclassified realm within general practice, was increasingly recognized as a field essential not only to clinical care, but to research and teaching. It was within this charged atmosphere that universities began to establish chairs, courses, and eventually departments of pediatrics, institutional structures that would endure and shape generations of physicians. In this transitional era, change did not occur uniformly or without challenge. Many traditionalists questioned whether childhood deserved its own academic spotlight, preferring to subsume it under the broader umbrella of adult medicine. Others struggled with the gaps that remained in knowledge, even as classrooms filled with eager learners and lecture notes expanded into textbooks. Fundamental mysteries about infant nutrition, developmental physiology, and immunity persisted. These intellectual tensions, between what was known and what was only beginning to be understood, injected a powerful momentum into pediatric education, compelling both teachers and students to push beyond familiar ground. By the early 20th century, the cumulative effect of these years was unmistakable. Pediatrics had emerged as a recognized scientific discipline, shaped by the ever-tightening bond between bedside observation and classroom inquiry. University crests now bore the insignia of pediatric departments. Research journals published case studies and analyses, and a new cadre of physicians entered the world of medicine equipped not only with clinical skills, but with a foundation in theory, critical thinking, and the eagerness to explore the mysteries of the growing body. This was not yet the zenith of pediatric science, but it was a turning point, a moment when the care of children stepped out of the quiet rooms of families and into the light of structured knowledge and collective endeavor. When we speak of saving children's lives, we must imagine both the quiet, intimate acts and the great public gestures. A nurse teaching a tired mother how to mix a simple solution by the light of a kerosene lamp. A council chamber where officials argue over the cost of installing a sewer. A laboratory where a scientist stamps a slide and wonders whether a microbe has finally yielded its secret. The battle against child mortality has always moved along these three axes. household practice, municipal policy, and scientific discovery. And the story of how the global toll of childhood death fell from a commonplace tragedy to something increasingly preventable is the story of how those axes aligned. Over the span of a single human life, entire societies learned to intervene not only at the bedside, but at the level of water, milk, vaccines, and education. And the results have been, in the aggregate, profound. The global rate of death for children under the age of 5 fell by roughly 60% between 1990 and 2020, where once 1 in 11 children failed to survive early childhood. In 2020, that ratio had narrowed to about 1 in 27. This transformation did not arrive as sudden miracle, it arrived by accretion. In the 19th century, the industrial city was a theater of peril for the young. Narrow alleys, crowded tenements, and wells near cesspits made an invisible foe of contaminated water and filth. The sanitary movement, a political and moral crusade as much as a technical one, began to change that landscape. Reformers argued that the health of the poor, and above all of their children, was not merely a private sorrow but a public responsibility. Commissioners of health, public engineers, and civic philanthropists lobbied for drains, sewers, and piped water. When those works were completed, whole patterns of childhood disease shifted. The records of cities that undertook large-scale sanitary reform show declines in infant and child deaths that could be traced to cleaner streets and safer water. It was slow, expensive, contentious work, but it altered the environment in which children grew from a place of endemic risk to one where survival was plausible. If sanitation remade the city, milk hygiene remade the infant's kitchen. In the age before industrial pasteurization, urban infants often drank milk harboring pathogens. Milk, meant to nourish, could carry the seeds of tuberculosis, typhoid, and summer diarrhea. For the poorest families, this risk compounded the dangers of overcrowding and malnutrition. The rise of milk inspection, the regulation of dairies, and eventually the adoption of heat pasteurization, the process that Louis Pasteur helped validate in laboratories, and that public health officials then translated into policy, turned a lethal vector into a safe staple. Places that adopted rigorous milk hygiene saw marked falls in infant mortality. Milk stopped being a routine daily hazard and became, instead, part of a child's recovery and resilience. That single change, technical and mundane, saved countless small lives and showed how a scientific insight could be turned into everyday protection. Alongside environment and food, the rise of immunization stands among the great achievements of preventive medicine. The practice of inoculation has roots reaching into the distant past, but the modern era of vaccination, beginning with Edward Jenner's work against smallpox at the close of the 18th century, unfolded into a century, and then a century and a half of successive triumphs. Measles, diphtheria, pertussis, tetanus, and later, a host of other infectious diseases once killed or disabled millions of children. Vaccines turned susceptibility into protection. As immunization programs expanded in the mid to late 20th century and afterward, whole cohorts of children grew up, spared the epidemics their grandparents had known. The historical arc is clear. Where reliable vaccine coverage penetrated communities, the incidence of the targeted diseases plummeted and childhood survival improved markedly. Yet vaccination also taught a harder lesson, that the protective shield is fragile when coverage falls. Periodic resurgences of vaccine-preventable diseases remind us that public trust and robust delivery systems are as vital as the scientific achievement itself. A second revolution of the 20th century was not flashy, but life-saving in a way that was almost brutal in its simplicity: oral rehydration therapy. In the 1960s and 1970s, researchers working in South Asia and elsewhere distilled the scientific study of cholera and diarrheal disease into a pragmatic formula. Replacement of salts and fluids by mouth could prevent the cascade of dehydration that turned diarrhea into death. That ingenuity made it possible to save millions of children without intravenous lines or intensive care units. By teaching mothers and community health workers how to mix a measured solution and administer it promptly. Over the decades, oral rehydration became one of global public health's most cost-effective tools. Estimates suggest it has saved tens of millions of lives since its introduction and remains central to preventing deaths from diarrheal disease in low-resource settings. The lesson here is moral and practical. Simple interventions, deployed widely and taught patiently, can yield enormous benefits. Public health is not only hardware and formulas, it is also education and the slow work of changing habits. Breastfeeding promotion campaigns, improved antenatal care, vaccination clinics, and teaching mothers how to prepare safe weaning foods are as crucial to lowering child mortality as pipes and pasteurizers. The 20th century saw the rise of public campaigns and institutions dedicated to child welfare, nurse visiting programs, well-baby clinics where infants were weighed and vaccines delivered, and school health services that monitored growth and caught developmental problems early. Where these programs were integrated with social supports, poverty relief, housing, maternal leave, their impact multiplied. Historical analysis has shown that improvements in infant and child survival in many nations depended less on dramatic new therapies than on broad social interventions. Sanitation, nutrition, maternal education, and accessible primary care. In other words, structural change mattered as much as clinical ingenuity. And yet the progress is not a single, unbroken arc. It has peaks and reversals. The late 20th and early 21st centuries delivered enormous gains worldwide. Yet the 21st century also brought new challenges: conflict, migration, vaccine hesitancy, and the fragility of health systems exposed by global shocks. Measles, which once seemed on track to be consigned to history, has resurged in numerous regions when vaccine coverage slipped, prompting renewed warnings from public health agencies. Outbreaks in recent years underscore a persistent truth. The tools of prevention are powerful but require constant stewardship, reliable supply chains, sustained financing, clear communication, and political will to keep them effective. The story of child survival is as much a political story as a medical one. What then are the lessons we glean from this long campaign? First, prevention multiplies. Clean water delivered to a neighborhood reduces diarrheal disease. A drop in diarrhea reduces the burden on households so they can feed and care for their children better. Improved nutrition strengthens immune response to other infections. Second, small technologies, if scaled, can be as revolutionary as lab discoveries. Heat, when applied to milk at the right temperature, spared infants from milk-borne killers. A powdered mix of salts and sugar, placed in a cup, stabilized children who would otherwise have been lost. Third, progress is fragile and uneven. Gains achieved in one century can be eroded in the next unless institutions, culture, and policy guard them well. And finally, the battle against child mortality is not the province of physicians alone. Engineers, mothers, municipal clerks, midwives, social reformers, and school teachers, all of them were crucial agents in the story. The narrative of survival is a social story as much as a medical one. If this part of our history has an emotional center, it is found at the bedside where public measures meet private grief. Picture a scene in a crowded urban clinic in the 1950s. The waiting room pulsed with coughs and the restless legs of hungry children. A nurse steps forward with powdered oral rehydration packets and a quiet insistence. A mother watches and learns. Across decades and continents, such scenes multiplied into a quiet revolution. The cumulative effect of public health and prevention was to change expectations about childhood. Survival became not merely a matter of chance but of policy and practice. Yet the work is never finished. Each generation must renew its commitment to pipes, to pasteurizers, to vaccines, to education, if the hard-won gains are to endure. In the next stretch of our story, we will follow how these public health victories shape new specializations within pediatrics. how departments of child health began to focus not only on treating disease, but on designing preventive systems, and how the moral argument that children deserve special protection became both a clinical credo and a policy imperative. For now, stand in that clinic doorway once more and listen. The sound is familiar across time: small breathing, the rustle of cloth, the murmur of instruction. Those are the sounds of a long struggle and of lives saved by measures both grand and modest. The emergent hospitals and pioneering figures of the 19th and early 20th centuries did more than save lives. They seeded an idea that would steadily change the very essence of how medicine viewed childhood. By the mid-20th century, pediatrics was no longer a singular perspective grafted onto general medicine, but a complex constellation of specialized disciplines, each addressing specific dimensions of growth, vulnerability, and disease in young bodies. This transformation, from broad care to nuanced, science-driven subfields, reshaped not only medical practice, but also how society came to understand childhood itself. Walking the corridors of a modern children's hospital today, one would find a structure unrecognizable from the wards of a century earlier. In place of general care for all childhood ailments, there are distinct units devoted to the tiniest newborns in neonatal intensive care, to children with tumors in pediatric oncology wards, and to young hearts in cardiology suites outfitted with cutting-edge imaging and monitoring. Each of these subspecialties arose from decades of scientific inquiry into why children differ not merely in degree from adults, but in kind, in physiology, in disease susceptibility, and in developmental dynamics. Pediatrics, once a single thread in the broader tapestry of medicine, had by the late 20th century become a tapestry in its own right, its weave and texture as rich as any adult-oriented discipline. Perhaps nowhere is this specialization more striking than in neonatology, the care of newborn infants, especially those born prematurely. In the early decades of the 20th century, infants born months before full term faced an almost certain fate. Their lungs, kidneys, and immune systems were simply unprepared for the world outside the womb. Yet as researchers studied premature physiology, and as physicians innovated with incubators, specialized ventilators, and intensive monitoring systems, an extraordinary transformation unfolded. By the 1970s, neonatal intensive care units, abbreviated in medical parlance as NICUs, had become a standard feature of major children's hospitals, offering dedicated support to infants whose survival once seemed impossible. These units did not emerge overnight. They were the cumulative result of clinical curiosity, technological invention, and persistent advocacy that the youngest patients deserved care tailored to their distinct biology. Meanwhile, other branches of pediatric science took shape in parallel. The blossoming of pediatric oncology, the study and treatment of childhood cancers, stands as one of the most dramatic success stories of 20th century medicine. In the middle of that century, diagnoses like leukemia were nearly invariably fatal in children. Yet early chemotherapeutic experiments and the systematic study of pediatric cancer biology gradually reshaped that grim outlook. Physicians and researchers worked through countless trials and setbacks before, by the 1990s, survival rates for some forms of childhood leukemia climbed to levels once thought unattainable. Today's pediatric oncologists treat not just cancer itself, but the array of developmental, psychological, and long-term survivorship issues that accompany treatment. Not all specialization was driven by disease categories alone. Some emerged from deeper physiological inquiry. The very concept of pediatric cardiology, for example, owes its rise to advances in diagnostic technology like the electrocardiogram and echocardiography, tools that made visible the hidden rhythms of a child's heart and allowed clinicians to diagnose subtle congenital defects long before they proved fatal. These innovations transformed pediatric practice, Today's cardiologists can intervene surgically or therapeutically in ways that were purely unimaginable in the early 20th century. Across the Atlantic, and often overlapping with these developments, academic medicine strengthened its institutional commitment to pediatrics. In the United States, the establishment of full-time pediatric departments, notably at Johns Hopkins Hospital, marked a turning point in how medical education integrated child health into its core curriculum. Under the leadership of figures like John Howland, who established the first dedicated pediatric department in the United States, pediatric training evolved from an add-on role into a demanding academic discipline. In lecture halls and research laboratories, faculty and students gathered to discuss not only clinical techniques, but also the latest research in growth, nutrition, immunology, and behavior, laying the foundation for future generations of pediatric subspecialists. The broader momentum of specialization also reshaped the institutions that cultivate pediatric expertise. Universities and medical schools that once offered general pediatric courses expanded their offerings into graduate-level training, research fellowships, and collaborative programs bridging medicine with psychology, nutrition, and public health. In the Soviet Union and later in Russia, for example, the St. Petersburg State Pediatric Medical University, originally founded in 1925, grew into a comprehensive center of pediatric education and research, with departments dedicated to disciplines as varied as social hygiene, child pathology, and pulmonary pediatric medicine. Such institutions embodied the belief that pediatric science was not only clinical, but deeply intertwined with social and developmental sciences. This diversification of specialization did more than create medical niches. It redefined the scope of pediatric responsibility. Where once the pediatrician's task might have been to soothe fever and watch a child's weight gain, by the latter 20th century, the pediatrician was expected to integrate a mosaic of knowledge about growth patterns, developmental psychology, nutrition science, and community health. This broadened role reflected a profound conceptual shift. Children were no longer seen as simply small adults, but as individuals undergoing dynamic physiological changes with their own normative curves, vulnerabilities, and resilience factors. While specialization accelerated, the field also became deeply collaborative. Pediatric subspecialties, cardiology, neonatology, oncology, endocrinology, and others, did not operate in isolation but interconnected through shared cases, research consortia, and clinical guidelines. Conferences, journals, and international societies arose where specialists could exchange ideas, debate treatment approaches, and build consensus around best practices. This networked culture of inquiry and dialogue reflected a maturation of pediatrics not as a single domain of care, but as a community of related sciences, each shedding light on facets of child health previously obscured. Yet, like all disciplines, modern pediatrics faces ongoing challenges. The very success of specialized science can create tension between hyper-focused knowledge and holistic understanding. A child born prematurely may need a neonatologist, a pediatric cardiologist, and a nutrition specialist, but also a family-centered care approach that knits these perspectives into a coherent life course plan. Moreover, the distribution of pediatric specialization varies across the globe. While well-resourced urban centers may boast sprawling pediatric departments, many rural or low-resource regions still struggle to provide even basic child health services. These disparities highlight the continuing interplay between scientific advancement and social context, a theme that has run through the history of pediatrics from its earliest moments to the present. Walking through a modern children's hospital today, one might hear the quiet hum of digital monitors alongside the confident, measured voices of specialists discussing complex cases, balancing laboratory values, growth charts, and developmental markers with the lived experience of childhood itself. Such scenes are the legacy of generations of innovation. Clinicians, educators, and researchers who slowly transformed pediatric care from a single outline into a constellation of science-driven fields. Their work underscores a central truth of this discipline's evolution, that attending to children's health demands both breadth and depth, an understanding of the whole child, and the ability to probe deep into specialized knowledge. As we look forward in this story, the concluding part will explore how the pediatric profession today negotiates the intersection of medical science, ethics, and societal expectations, how it carries forward the tension between individual care and public responsibility. For now, imagine the hospitals of the 21st century, corridors of care where subspecialties converge, where science and compassion walk hand in hand, and where each child's unique journey continues to challenge and inspire the practitioners who dedicate their lives to understanding it. The long arc of history bends toward a view of childhood that is at once scientific, ethical, and deeply social. When the first dedicated wards for sick children opened in Paris in the early 19th century, that act alone was transformative, a public acknowledgement that childhood matters not only to families but to society. Over the ensuing centuries, caregivers and researchers took first tentative steps toward understanding children as unique creatures of growth, vulnerability, and resilience. By the 20th century, this awareness had blossomed into an array of specialized sciences, from neonatology to pediatric oncology, each probing the mysteries of life's earliest stages with tools unimaginable to the physicians of old. Today, the story of pediatrics is woven from threads of clinical innovation, public health, social policy, and ethical reflection, and its future promises to be no less rich and complex. At the heart of this legacy is a simple, profound recognition. Children are not merely smaller adults. Their bodies and minds follow developmental pathways that require tailored understanding. From the earliest efforts to record childhood ailments on papyrus scrolls, through the pioneering clinics of Abraham Jacobi and August Honor, to the bustling research laboratories and specialized departments of the present day, a central motif emerges. Childhood is an object of medical inquiry, not a side note to adult health. As research evolves and the demands on pediatric care change, the discipline continues to ask new questions about the nature of growth, disease, and well-being in young lives. Yet it is not only the science of pediatrics that bears this legacy, it is also a set of social commitments. In the 20th century, public health programs endeavored to make survival and healthy growth a norm rather than an exception. Global initiatives, such as the expanded program on immunization, helped extend the protective power of vaccination to children around the world, contributing to a dramatic reduction in preventable childhood deaths. Between its foundation in the 1970s and the present day, this program has prevented millions of deaths among infants and toddlers, showing how stable, reliable immunization schedules can reshape societal expectations of childhood survival. Still, the future of pediatrics and the science of child health lies in both continuity and change. Scholars and clinicians now work at the intersection of medicine, technology, and society. They explore how genomics might inform personalized pediatric care, how artificial intelligence could refine diagnostic precision in neonatal intensive care units, and how social determinants like housing, education, and nutrition shape long-term child outcomes. These frontiers extend the discipline beyond the walls of hospitals and into the lived contexts of children's everyday lives. But the future also reminds us that progress is neither linear nor guaranteed. As medical needs evolve, so too do social and political challenges. In some regions, access to child-focused health services is contracting, with hospitals closing pediatric units due to financial and staffing pressures, leaving underserved families to travel farther for care. These developments underscore a tension in modern medicine. As science advances, the infrastructure and policy that sustain access must keep pace. In other arenas, debates about public trust and policy continue to shape the terrain of child health. When national immunization schedules are altered or public health authorities face political pressures, societies must grapple with balancing evidence-based practice, community values, and individual choice. Such episodes remind us that pediatrics is always embedded in the broader cultural currents of its time, subject to the ebbs and flows of policy and public sentiment. Yet even amid such challenges, the principles forged across generations endure. Pediatrics today is not simply about treating illness. It is about preventing suffering, promoting development, and advocating for the conditions that allow every child to flourish. The discipline's community, from frontline clinicians and researchers to public health professionals and educators, recognizes that children's health outcomes are interwoven with the quality of their environments, the equity of their societies, and the stability of the systems meant to protect them. The legacy of pediatric care also teaches us that listening to children and their families is a scientific act as much as a compassionate one. Measuring growth curves, monitoring developmental milestones, and interpreting behavioral cues are all part of how medical science disciplines its curiosity into care. As pediatric research expands into fields such as longitudinal child development, neurobehavioral science, and global health disparities, the scope of inquiry broadens without losing its focus on the lived experience of childhood itself. When historians look back upon the evolution of pediatrics, they see more than a catalog of discoveries and institutions. They see a transformation in how societies articulate their moral obligations. Once, children's lives were largely left to the vicissitudes of family care and chance. Now, through research, specialized training, and public programs, countless lives are spared what was once commonplace suffering. And yet, each generation must renew that commitment, crafting new policies, sustaining equitable systems of care, and ensuring that science serves the broadest possible community. In the final tally of human history, the legacy of pediatrics may be one of expanding circle, moving from individual bedside interactions to global networks of prevention and care. The future, with all its technological wonders and social complexities, presents both opportunities and responsibilities. To harness advances like big data and artificial intelligence in ways that expand access and understanding, to keep child health research vibrant and inclusive, and to safeguard the social conditions that allow children everywhere not simply to survive, but to thrive.